ethics and communication process with parents and patients in childhood oncology. I hope we all agree that this is a very, very important issue for all of us, not just for the patients or the parents, but also for you as physicians and also for your colleagues, the nurses, the psychosocial team. And as we also all know, communication can bring, many opportunities and chances, but can also be quite tricky. And oftentimes things that we say or we think that we say and are heard and understood by the other person might not be heard as we said or that as we wanted them to understand. So when Frederick and myself were preparing that session, we thought, okay, we are not ethicists, and we are also not communication specialists. So what we can provide here today are some experiences, maybe from our own experience, but also from what we hear from our community for the parents, the patients, and the survivors we work with. So this is what we are going to do today, and also I will make you interact a little bit. So I hope you are up for this. Exactly, so Jelena explained everything, so I don't need to say, give the context. Okay, so maybe some of you remember that slide from last year. I decided I would have it again, so breaking the bad news or also a bit dropping the bomb. And we know that more than 50% of the parents report that they basically take in very little or even none of the information that is given to them in such a very stressful, impactful situation. And I can, from my own experience, tell, so I was 17, I was diagnosed with a Ewing sarcoma, and they tell me that, and I mean, you have never heard of that before. I mean, how can you as an adolescent have cancer? You hear of old people who have cancer, but children and adolescents, and then you are confronted with this information. And I remember sitting in that bed, and that wasn't in the pediatric treatment center, but in the adult ward in one of the biggest centers in Austria, like hospitals in Austria. And I was sitting there, and I heard only this, and everything afterwards I didn't hear anymore. So I heard that the person was talking, but I didn't take in at all what they were saying to me. I remember my parents standing there. I remember the old lady that was with me in that room. And I remember her saying, oh, come on. No, you know, my husband, he also had cancer. Oh, come on. This will be fine. This will be fine. And I just thought, hey, just leave me alone. That's not your place right now. That's not everyone's place right now. Just let me go home back. And yeah, so basically, I didn't hear any of it. And so here, I think it seems so clear, but so it's so important to make sure who can I call as a patient, as a parent, if I have any questions? Because the doctors may leave the room, then maybe the nurses come in, or maybe even a psychologist, if you are lucky that there is one in the center that you are at. So who can I ask if I have questions, and who is responsible for which kind of question? Because also I should know that, right? Who can I turn to? And then also, where can I find information when I'm home? And I also think that we agree that place maybe is not the internet, or maybe not the internet is the best place to find information. So what can you give the parents and the patients to look at it at home? And then when we come to this part, the written information, I would also like to just pick out one result that a survey that Frederick did with the French National Parent Organization. And they asked the parents, were the written documents that you received useful and were they clear? And shockingly, but maybe not surprisingly, I don't know, 78% of the parents didn't say yes. So they said either no or just partially. So I really think we should also, and I'm not even going into the topic of informed consents at this point. So we should ask ourselves the question, if we are handing out information, is it clear, is it useful, is it in a language or maybe even in graphics that can be taken in easily at home, when you are at home? And then again, does it say anything there? Whom can I ask if I have further questions? So, and then another thing in communication, I think, which we all know. So habits, there are habits, there is avoidance if we are having uncomfortable topics to talk about, and also then we have social desirability. And these are maybe small things that have quite some impact. So what I could see, and I also worked so I'm a psychologist by professional background actually, and I worked at the unit for pediatric brain cancer patients as a research coordinator, and we were very often discussing together with the team who are having interdisciplinary consultations with the patients. And they so often say, it's so interesting, so the psychologist and the social worker say, when we are in there together, so patient, parent, or survivor, parent, physician, and one of the psychosocial team, and the oncologist is asking, hey, how is it going? How are you doing? Yeah, it's good. It's fine. I'm good. And then outside, they approach maybe the psychologist or the social worker, and they say, yeah, we have so many problems. And it's like in school and at home and with the siblings and at work and so on and so on and so on. So what we can see is that the patients and the parents address different questions and different concerns to the different team members. And so I think we should all be aware of that. And ideally, we have a multidisciplinary team, a multi-professional team. Maybe we have psychologists who follow up after the conversations, who come visit in the room again and address some of the things that we know could come up. And then there is one more topic. So when it comes to uncomfortable issues maybe, or things that are hard to tell, are we explicitly addressing that issue, or are we just implying that issue in order not to speak it like directly out? And I, for instance, I remember one situation that was very striking for me in follow-up care. So to me, the topic of premature ovarian insufficiency was never explicitly discussed. So basically, I found out myself over the course of my follow-up care, and then at my very last appointment, of course, there were the results and so on, also hormonal status, and then the doctor was sitting there and was saying, yeah, and about that, I mean, yeah, look at the results. I mean, this, yeah, will be difficult. And so that was, I knew it already because I had found out like previously, but it was a situation where I thought, we are adults. I'm an adult, I was 28 at that time. We could address this and talk about it, and that would be helpful. So I think here it's always worth, even though some topics are difficult or uncomfortable, can we find a way in saying it very explicitly, making sure that the message is received as it is, and maybe can we then help and follow up with some support that is surrounding this issue. And then also we should always, I feel, be aware of how are we introducing or setting the scene. Maybe you know that, I know that also from myself when I'm meeting with someone and I open the situation and I say, oh, hey, hi, hey, you look good, how are you doing? And what will the person probably say? will the person say, well, to be honest, I'm not feeling really good because of da da da. Probably the person will say, oh yeah, I'm good, thanks. Yeah, I'm good, thank you. And so also here, I think if we are interested in how the person is, then maybe we should just say, hello, how have you been doing? What's going on in your life? How has school been? How has work been? How has whatever, sorry. How is it with your friends? Because then maybe the person will not feel the pressure of social desirability. And we all know it. We do not want to disappoint our opposite person. And in saying, well, actually, I'm not feeling well, you might disappoint the other person who just felt, hey, you are looking good, you're looking great. And maybe, yes, compared to, I don't know, during chemotherapy or during radiation, maybe yes, maybe compared to this, hey, you look great. But maybe the person is not feeling great, in fact. So, this was some input, and then here. So, I know you have heard in the past days about neuroblastoma and Morbus Hodgkin. And I saw also you have discussed treatment options and also risk stratification and so on. So I was wondering what might the social surrounding of these patients look. And so I imagined, and probably that's not true, but I imagined in my head the patient, the 11-year-old boy with neuroblastoma. He has parents who are divorced, and his parents do not have quite a good relationship, so it's rather hard. He lives with his mother and his younger brother, who is 8 years old, and they have a very, very close relationship. So the little one is really looking up to his older brother, and and also the brother has a hard time understanding what's going on. Why is my brother not at home? Why is my mom not at home? Why am I so much with my grandparents? And also, the patient himself, he just wants to go back to school. And he wants to go play soccer with his team and not be here and be in pain and in uncertainty. And then, the 17-year-old female patient, she is in her last year of school, so a very important time in her life. She lives with her parents and her younger sisters, but she wants to be independent. So basically, she was actually going out before all of this. She was partying, she was disobeying any rules in their house. And now she's like in the hospital, and she is controlled by the outside and has no control over what's happening. She can say, no, I don't want that, but what impact does that have? So basically, she's just pissed off by this whole situation. So, what I would like you to do in a few minutes. So what we did, we were thinking of some, for neuroblastoma, the neuroblastoma patient and the Morbus Hodgkin patient, some questions that might be useful on the side of the treating team to consider, to think about, to discuss. What are the angles? What are the implications? How could I explain this? How could I explain that? And I will go to these questions in a second. And maybe you want to take a picture of the questions. And maybe you also want to take a picture of this. And you already also can think a little for yourselves which case you would like to work with in the next, let's say, 20 minutes. Okay. Okay, so then, with our neuroblastoma patient, we will give it a little time to think about the question, how much time do you give the parents, the patients, to think about it? So to think about the treatment options, to think about what maybe, can be done. I mean, fertility preservation, for instance, does not say so here, but for the other patient. And then also, do you have an announcement ritual? So how are you introducing the facts to the family? How are you introducing the options, what you found out, what this means for everyday life and also for the future of the patient and the family? And then there's, of course, the question, and I think this is the thing that has a big ethical implication. Do you disclose everything to the patient and to the parent? Do you discuss with the parents ahead, maybe also, what you should disclose or what not? How do you deal with cultural differences that might come up? And I really think that, especially now in the light of the war in Ukraine, where in many, many treatment centers, there will be many patients from Ukraine who have experienced the most horrific thing, that we probably can imagine. Also, there are cultural differences. How do you handle it if parents say, we do not want our child to know anything at all what's going on? Or vice versa. How do you deal with that? It's a tough one, I know. And then also, maybe, if it's about new therapies, innovative treatment options, and then also the information on the internet. So how do you tell the patients and the parents? And also when they are asking for more information and say, hey, can I Google this? Where do you direct them? Do you have other sources that you can direct them to that may be safer in terms of better information? Then when it comes to clinical trials, how do you make sure that it's clear to the patients and to the parents that this treatment may not be curative? And then, how do you address late effects? Do you address late effects at that stage? Can this be dangerous? Maybe dangerous in terms of, am I risking that the family will drop out and say, no, I won't have that treatment? And then here again for the Hodgkin patient, basically the same at first. Here also the fertility preservation comes into play. So how are you going to do this? Maybe there is not much time, maybe there is very little time until the treatment has to start. So how do you explain to them? Do you leave the option? Do you say, we could do it, we would need to delay the start of the treatment? Or do you say, we would really recommend not to do this now because, I don't know, maybe that's not the priority right now? And then, in this case, how do we explain what risk stratification is to the parents and to the patients? How do you break also, for instance, that they are high-risk patients? What does that mean? And what do you say about the different treatment options that come with the different stratifications? And also, could it happen that a family says, couldn't we try with a little less? What will you say? How could you address that? And also maybe on the other possibility, maybe the family says, yeah, but just to be safe, couldn't we try more, better? And then also here, do you tell them everything? And is it a good idea to tell everything? And how do you address late effects? When do you address late effects? Do you do that at the start? Or do you wait until the patients come into follow-up care? And also then, do you address it at the beginning of follow-up care? Do you address the things that could happen because of the treatment, because of the cancer? Or are you addressing the thing that happens when it happens? So I think we can slowly come back. We have 15 more minutes to discuss all together. No, we don't have a couple of more minutes. No. So Andisha and I were just talking that sometimes the oncologist also needs to set the frame for the conversation. So this is what we are doing right now. Okay. Thank you. So of the 20 minutes plenary, it's now 15 minutes, but I think we will manage. So, how did it go? Is there any group who would like to present or start the discussion with the others? How did it go for you? Yeah.
Okay, so we're gonna start this discussion, and as I'm wearing, what am I wearing? The yellow glasses. From the pediatric oncologist's point of view, when you set aside the fact that I really don't like role play, I also experience in real life what you said in the slide, this, oh, how are you? You look so good, that you suddenly, if you have to address difficult topics, you can find yourself in a situation where you as a person feel really uncomfortable. And this is where conversations can go wrong, because then you focus more on overcoming you feeling uncomfortable and making yourself feel better in the conversation, that you subconsciously forget that you're actually here to be clear to the patient and to make the patient feel better in the situation. So that's what I've just now experienced, even in the role play part. And then what we said is, as an introductory ritual, to sort of set the scene, it's good to have a personal introduction to explain who everybody is in the room. And then personally, we had the Hodgkin's case. So as the patient is already a young adult, basically, the conversation should go towards the patient and not towards the parents mainly, even though the parents would like the conversation to be about them. But here I might hand over to my patient.
So I'm the patient. What I would like to comment, and I find really important, is that I just heard from the oncologist here the sentence, if we don't treat it, then you're going to die. And then I just, it was, so I'm sorry, I think, and then I was so shocked, and I told her, do you really use this sentence in the clinic? Because I don't really feel comfortable as a pediatrician, not as a patient. And then she reframed and she said, okay, I would say if we don't treat it, then you're not going to survive. And I thought, okay, now we are talking about survivors. No, but I think that's important, because sometimes the patient does just keep 2 words. So I'm not really listening to you, but I just keep in my mind 2 words, because if you say die, then I will remember that. It's not something that I'm gonna forget. So sometimes we have just maybe to have standard phrases that we could use or we don't have to use, I guess.
Okay, can I have my microphone? So just... Okay. I want to answer that. Just to clarify that, when we were talking about this, we were already out of role play, so we were talking about how to...
But I think you bring up a very important topic by raising this. Karina, would you like to comment on the fact that we know that it's true that if we don't treat Hodgkin's, patients will die from the disease? How would you address this topic that they are discussing?
I'm not multitasking. Could you repeat the question, please? Sorry.
Sorry.
Okay, so what would...
This topic is, I think, important to discuss. That we all know that if you don't treat Hodgkin's disease, patients will die from Hodgkin's disease. And if this comes up very early in the conversation, what do you think about this?
Yeah, I mean, it's a fact. Period. And so what I was thinking now, I mean, the message came across. So that for sure, not saying, I mean, that I, as a patient, if that's what I heard, so either we treat you or you die, might be a little... No, but that's not the... Often, it's not so important what the one person says, but what the other understands. And so I think, I mean, if we have the feeling, okay, maybe is there an issue that the patient might refuse treatment because 17 years old, because school, because life, because fuck it, sorry. How can we find the words to make clear what the situation is? And I think,
So we were just discussing in our group that it would be very rare for any of us to go into a room to a patient we've never met and say, hello, my name is Rahil, you have Ewing sarcoma, have a nice day. So a lot of the time it's a stepwise process. So the patient has come in the night before. For instance, I'm just going to say my approach to it, but you know, we will prepare with the nurse. What do they know? What don't they know? How are they? Who am I going to meet? You go in. Often I try to make either the 17-year-old or the parent tell me, okay, so it's something you have pain in your stomach. How long has it been going on? They'll tell you ourselves. Okay, and they found a lump. Yes, that's why you're here. Okay, so in the next hours, this and this and this will happen. We'll meet again. You may go in 1 hour later. Do you have any new questions? And then next step. And then finally, at some point, you arrive to a place where, okay, so now we know each other. We've been looking for these things. And then, you know, maybe sometimes they will say, I'm really scared. I have cancer. Yeah, unfortunately, yes, you have cancer. It's called Ewing sarcoma. And then also with if we don't treat this, you will die. I think most people know that if you don't treat cancer, you will die. So death is not something that I speak about very early. Of course, it's addressed that it's a serious condition. We need to treat it. But always, for me, it's a more stepwise approach than like hello, Ewing sarcoma. Yeah. I'm also quite surprised that that's your experience of it.
This is some years.
So again, it's for me, my perception stopped after what you have is a Ewing sarcoma, and that's cancer in your bones. He kept talking, and he said, okay, you will be transferred this afternoon to the Paediatric treatment center. So for them, the job ended there, basically, because they knew they are not the site where I would be treated. And they did explain some things to my parents. I know that because they told me. But for me, it stopped at you have cancer.
I think this situation that she experienced is not so rare, because we all get patients transferred to our ward, and the diagnosis of cancer was already known in the transferring center, but they didn't tell them anything. Suddenly they step in my ward, they see all the patients without hair, they heard St. Anna, Children's Hospital, Oncology, and are shocked. So the question is, what do you think, or you think, what the transferring centers, the peripheral centers, should communicate to the patients? my personal view is they should already talk about cancer. This is my view on this thing, but you can perhaps see it differently.
Often you're not sure. So
No, I'm just talking about sure situations. We have patients in which a lymphoma was diagnosed. The doctor gets the information from the peripheral center, call them on the phone, send them, go to St. Anna Children's Hospital without saying anything about cancer.
no, often you get the patient.
But I'm just talking about patients
Yeah, yeah.
the diagnosis is already clear.
Yeah, but I'm also shocked sometimes that the referring hospital is more sure about the diagnosis than you are as an oncology center.
And yeah, Reneke just pointed out on one thing that also Rahel mentioned during night shift. For example, we are University Children's Hospital, so whole scope is there. And it happens once that my colleague, who is pediatric neurologist, was present when I was giving a lecture to primary care physicians, you know, about the treatment, then, for example, the maintenance therapy in ILL, how they can, for example, do CBC and call us for them not to travel like 300 kilometers, 400. And he catch some points. And they admitted a child during the night. He called me. He sent a photo, actually, the Viber medicine or WhatsApp medicine, and of course it looks like leukemia. So he approached to the parents, said that the child has leukemia, and start to explain treatment protocol because he heard 3 days ago. And this is something that should not ever happen. Yeah. Because when I came in the morning, so that some info were not put on the right place from the parents, and I was like, what?
No, I just wanted to say often we have the children coming to us for peripheral hospitals because of the suspicion of cancer, and they need to come to us to confirm with a biopsy, etc. But it's the responsibility of that centre to explain why they're coming to us and that it is a cancer centre.
Would you recommend that transferring
We-
doctors say one of the differential diagnoses is cancer, that's why you transfer to the
Yes,
center?
I would, yeah, because they'll see all the children.
I just think it's the main responsibility, and I would say tell them what you know, like what you know 100%. So if you know 100% this is ALL or Hodgkin's, then okay, you can tell them, but they often don't know. They know there's a lump in your stomach, we did a scan, and we're sending you to this department. You will see both children because this is a cancer department, and that is one of the differential diagnoses. This we know.
Yes, but you're sending to a cancer department, so it's even clear for the patient.
Yes, you can say that, yeah, we're sending you here because this is what we're thinking.
We've had a similar experience in Nottingham of a child who had a CBC done and it looked like leukemia, and the GP sent them to the cancer ward but didn't tell them that it might be cancer. And I think if you don't tell them anything, then you risk undermining the trust of that family and all of the health professionals because we're not telling them the truth.
Especially a GP, that may not see many children with cancer. I will practice with them what they're going to say.
So I asked the GP, what are you going to tell them? And then we can discuss it.
Yes, yeah, exactly. But to say
If they
something,
call.
just to explain why you're going to a cancer ward.
Yeah, I think every one of us had similar situations, but I think it's really important to tell the suspicion at least of diagnosis, because we had situations, I don't know how it is in your countries, in which patients were sent on weekends. Friday night, Saturday in the morning. We do not have the possibility to do the tests until Monday, and I think it's really unfair for the parents not to know why they were sent to another department, to another city with their child, and to not to know why they are there. What's the suspicion? What should they wait for, actually?
Completely agree with you. Karina, you would...
No, I
No,
Just a fact.
Okay, but you're the moderator of the next group, or is there anyone else who would like to comment on this? So how did the conversation go on?
Don't ask. We don't have time.
Next one. Who wants? Which group would like to tell Karine and us what they? Neuroblastoma, Hodgkin's. Should we change to one case of neuroblastoma and then come back to you? Neuroblastoma?
Here? Nobody neuroblastoma?
You? Neuroblastoma? Or you? then I give it to you. Neuroblastoma case.
I think that we all agreed then that we have protocols in different centers on how to give and explain the diagnosis to the parents. And first of all, that so it was called spikes in your case, whatever the name is in the other centers. But first of all, that so we should maybe tell the parents, or in this case the mother, ask if the mother wants the father to be there because the parents are separated. Do they go along well together? Because it's important what you're going to say once we have the diagnosis, of course. Do we do it separately, the two parents, because the father has to know if he has some legal option with the kid, and then that we should really have some time, get into a room, a calm room, get maybe our cell phone to someone else, and have a real time prepared for being with the parents, and that then maybe once we tell the diagnosis that we have also a plan of saying, okay, maybe this is a cancer, because we have to tell them where they are and what for, but also that it is a curable disease, of course, and then have a plan as well of treatment and what is going to happen, and that we do not work alone, and that they will enter a protocol and be taken in charge in a specialized center where the doctor does not work alone, but with the psychologist that they're going to meet, with the social worker that they're going to that they're going to see, with as well nurses that will take care, and physiotherapists. I mean, present all the team, and then say that they're going to get more information with different time points. But that was a bit how we presented the thing. No, but I mean that there are options, because that we're going to try at least.
Yes, you have to leave some hope. May I ask one question? It's an 11-year-old boy. Was the boy included in the primary conversation, or did you talk with the parent alone and then afterwards in a kid-directed language with the kid? How did you decide? A second question from me. You said stage 4 disease. What do you answer if it's in a really stage 4, not stage 4S? If the parents ask you what is the overall outcome of stage 4 neuroblastoma in the first conversation, which happens, it's not so rare.
Yes, we discussed that as well, and I mean maybe we said one of the answer we can give that your child is no percentage, and that it's. For the parents, it's either 0 or 100%, and that they should consider, if the question is so important for them, to know the percentage, but that we are going to do everything we can, of course. And
you would say the truth, that it's, let's say, 40%, if they want to hear the statistics.
Yes, I think if they want to know, we have to tell them, because otherwise they're going to figure out whatsoever. So I think it's...
And we are obliged. From legal point of view.
And we need to be frank with them.
Yeah. No, I agree with you. I just wanted to hear what you have discussed in your group.
And like we had said before, I think it's important to build trust right away, because if you're on your first encounter, you're going to lie to the patients, you're going to lose the trust, and you have a whole journey in front of you. So if your first impression is horrible, it's going to be downhill from there.
That's a trick.
That's a trick, but we can use tricks as well.
Yeah, and And yeah, about the percentage and about the question, is the percentage really so important to you that you need to know? I think this question, as a parent, would make me feel bad for wanting to know the percentage. So it could be that I stop asking about the percentage, but actually it bothers me quite a lot because I would like to know, because I would need to know maybe for me. So I think this is also something to consider.
But also, doesn't this answer imply that it's bad? And then you imply the percentage is really bad and that they shouldn't ask? So that's all I want to say.
I think we are over time, but I think we have time for two or three comments or questions. Short.
Oh, thank you. So I would just briefly wanted to comment. I think I would first hand see if I can talk to the family with the 11-year-old, unless the family have indicated somehow that they don't want that. Then I would start talking to them. But if I can, if that would be my first option, to be honest. I would sit with the family and the 11-year-old, and I think I would like to address him, unless he starts deferring to the parents or they take over. But I think I would try to make him a part of it as quickly as possible. And then that's the one thing I wanted to say, and the other one was. For statistics, I tried to simplify we had this commercial by the Swedish Barncancerfonden, so the fund for pediatric cancer, and they had so it used to be 4 chairs, and then there's 3 children sitting on them and an empty chair, and I said nowadays if they would have made it again, almost everyone has seen it in Sweden, so I say it should be more like 5 chairs and 4 children sitting on it, and then if it's different from that, and I say yeah, this is Wilms, so this is for any cancer in pediatrics. So for Wilms, the outlook is better, and if it's worse, then I would comment on that. This is a more difficult case.
Okay, 2 last comments, one from you and one from you. Then we'll stop.
Okay, what I wanted to say was that I didn't want to become a pediatric oncologist in the beginning because I thought that all the children that have cancer die. And that was wrong. And we are really happy that we have in ALL like 95%. What do the parents know that we have this good prognosis to the treatment? Because with 40%, maybe that won't sound really bad for the parents, because when they hear that they have a child with cancer, they think, okay, the child is not going to be cured. But with 40%, maybe they're happy to hear it.
Thank you. No.
I just wanted to disagree with my colleague. I think it's really important for the first discussion with the parents to let them have their natural reaction to the diagnosis. And if the child is present, they might try to inhibit the reactions, not to cry, not to tremble, not to have, not to shout, not to go into shock. And that's not okay, in my point of view. And on the other side, if they cannot do that and they start crying, it is really, really bad for the child to see their parents react like this, because they realize they're really, really, really sick. And I don't know if that would be okay. So basically, in our country, when we tell the diagnosis at first, we only have the parents in the room. We let them digest the information.
Sorry, also for a Hodgkin's disease, 17
it doesn't
and a half
matter.
years?
It doesn't matter. At first, we talk to the parents. We let them take in the diagnosis, and then we talk to them, and we ask them how they would like for us to tell the diagnosis to the child. Would they like them? No, would they like it to tell them themselves? Do they need any help? Do they need a psychologist? Do they need a doctor? What kind of reaction would they expect from their child? Because it's so diverse.
I think we have to finish.
I just want to comment, and we were just looking at each other in our group, so 4 people, 3 countries, and 2.5 approaches, let's say like that. So not 3 completely different approaches. And Denmark, as you said, from Sweden, so the Scandinavia has completely different approach. You, as from Romania and Serbia, are different types. Our parents are overprotective, and you need to first to, yeah, I see, from Bulgaria the same. So the Balkan countries are really different. Parents are overprotective. You need first to ensure the trust of the parents, to let them be, and then get the child on board. So completely different, yeah.
Yes, and Karine and I, we were talking before, and I think even this topic that Karina brought up during this session is not black and white. And I think we have to accept that there is a really gray zone. And I think your way may work very well, but also what you were saying is very right. I agree with you. So I think we cannot say that the one way is correct, the other one is not correct. But Karina, the last words are to you.
Yeah, I just wanted to say that I think what has been discussed right now is exactly pointing to the importance of considering cultural differences when we are together. And for me, and that's like working also in EU-wide projects and in the EU-wide family, this is so interesting to me so often, because we can see in these projects we need to accommodate so many different approaches, and it can be super hard to come to a joint, like to a consensus. But it works. No, but I think that this is the issue, and there are cultural differences and there are individual differences as well. Sorry?
From their education.
Yeah. So yeah, exactly. Yeah, and so I think it's clear that not everyone is the same, and I think that's the tricky part for the treating team, trying to adjust to lay back your own and what would you think is best, and really try to figure out and read and hear and feel and see what might be the best.